Okay, thank you so much. So I need to explain a little bit about the title. I'm a neuroradiologist and I deal with a lot of brain tumors. So the main reason I came up with this project is you saw some images of, there are MRIs of brain tumors that MRI doesn't really show anything, but there's a lot of stuff happening beyond the resolution of MRI. So I asked myself, okay, what else can I do to see more than just purely structural imaging? Well, how can I image physiology and pathophysiology? Hypoxia is actually an entity that involves almost every solid tumor. And hypoxia, in short, is bad. Why is it bad? Hypoxia induces, this is my disclosure. Hypoxia induces cancer stem cells that are by nature more resistant to chemo and radiation. In terms of primary brain tumors or glioblastomas and gliomas, hypoxia also activates some pathways that increase an enzyme called MGMT that causes resistance, further resistance to temozolomide. So again, hypoxia is bad. So there are a variety of reasons. So I thought, how can I come with an imaging technique that I image hypoxia in the brain tumor? And you might have heard about qBOLD imaging, functional imaging, when somebody moves their hand, something lights up in the brain. This is a different flavor of that kind of imaging, but you deal with numbers and you quantify what's happening. Taking a step back, why is it important? Obviously, more than 77% of primary brain tumors are gliomas, and the most common primary brain tumor is glioblastoma. We know, we've seen glioblastoma is extremely heterogeneous tumor. This was actually the first tumor that was mapped in Cancer Genomic Atlas. So this is one of the biggest mysteries. And still, despite everything we've done, we are doing very, very poorly in terms of treating. So at least from the other flavor, from the diagnostic portion, let's see what we can help. So I explained a little bit about why hypoxia is bad. So how can this help us? So if I can have a map of tumor before radiation or before surgery, I know this part of the tumor is more hypoxic. I know that part of the tumor is going to be more resistant to treatment. So if we are doing any surgery for any gliomas, if it is possible to be more aggressive towards that part, that would be a good thing. If we're doing radiation, and after the end of radiation, we can do another oxygenation mapping of the brain, and there is still areas of hypoxia, we can try out a radiation dose boost with SPRT. So we just try to find out a way of doing this and measure the numbers. And what I wanted to have a real number. So we say this part of the brain, the hypoxia is this %. So this is the oxygenation of that part of the brain. So what we use, as I said, is quantitative blood oxygenation level dependent MRI to non-invasively measure oxygenation in brain. Currently, if we want to use it, we can use PET, but there are a couple of issues with PET. Number one is PET is less accessible, it's expensive, and PET imaging tracers that can image hypoxia are expensive and, again, not widely available at all. They have very short half-life, and it's technically impossible to do it on a larger scale in clinical practice. But you have MRI everywhere, so if you can do this, you can do on every single MRI scanner. And our point was to find out the technique that you can do it on any MRI. So we use an agent called ferromoxetol. So what is ferromoxetol? Ferromoxetol is actually an iron supplement, IV iron supplement. It's commonly used in patients who have iron deficiency anemia because of chronic kidney disease. But this agent happened to have some magnetic magics because of its structure. Remember, MRI is a big magnet, so if this agent is called ultra small super paramagnetic iron oxide particle. So just imagine this is iron, a lot of iron in a magnet can do a lot of things, and that's what we do in MRI. So all we do in MRI is just changing the magnetic field to see how the tissues react and to image that one. So we are using that characteristic of having iron in blood vessels. So we're using technically a iron supplement as an MRI dye. This one was done in a limited fashion in animal models, but nobody actually proved it, what it showed. So there are studies that in animal models that say, okay, this is part of the brain is different, but we don't know what that difference means. So what we wanted to do, we wanted to see, one, it's possible in humans, and second of all, we wanted to validate it. How are we going to validate it? That was the hardest part of my project. So I proved that I can do this study, I can come up with these maps, so I need a surgeon willing to help me set up my stuff in OR to put actually oxygen probes into parts of the tumor intraoperatively. And actually most of our cases that we've done, Dr. Das, who's sitting here, actually was a surgeon. So what we did, first we need to find the patients, then we use the ferumoxytol or iron-based MRI imaging to image oxygenation in brain tumor. So I don't know if we have a pointer, but where is the pointer?
It's on there.
It's on this guy?
Yeah. I think it's
is this
that
one?
button. Yeah.
Okay. So this is what you see in a normal structural MRI. These stuff are images that we do throughout our research project. We image brain before injection of ferumoxytol, after injection of ferumoxytol, and this is our end product. This is a quantitative map of brain that shows oxygen saturation in every single pixel of your picture. And we wanted to prove that this is right, so we can just translate this to clinical practice. So what we did, we came, for example, in this patient, this is a brain tumor here. We draw a region of interest in this part of the tumor, and then we translate these ones to intraoperative neuronavigation machines. Again, this is one of the patients that I did with Dr. Das. What we did through intraoperative neuronavigation, we targeted these areas and put the tip of the oxygen measurement probes into those areas and measured oxygenation intraoperatively in vivo within those areas. And we already had quantitative measures from our MRI. We wanted to see if these are similar to what we did in terms of our calculations is similar to what's happening in real life. At the same time, after we did our measurements from it doesn't go back, I guess, that's fine. From all these little dots that you saw, we also took samples, and we sent those samples for pathology markers of hypoxia. So what we did, we recruited 10 patients, six ended up being GBM and 4 lower grade gliomas. And these are the values we calculated with our MRI. So there are areas that have low oxygen tension, there are areas that have high oxygen tension, and these are areas that are measured by Lycox system or the probe system. So you may initially say, okay, these numbers don't match, but remember what we measure in brain, in MRI, we measure oxygen saturation. What we measure with Lycox, we measure tension. So there is a lot going on to translate tension, oxygen tension in the tissue to oxygen saturation, depending on local tissue pH, local temperature, oxygen that comes in blood, in arteries, oxygen that goes in veins, oxygen that the patient breathes, and everything is changing. But if in a single patient, if we use one tumor as a local environment, we can just divide these numbers together so to kind of compensate for local effects of tumor in each case. And that's what we get. So if we divide high to low of the Lycox system, or probe system, to high to low of our MRI system, we have pretty good correlation in terms of what we see. But further on to further validate our technique, we stained pathology samples from those areas that we measure oxygenation. One is HIF1 alpha. So HIF1 alpha is a very well-known tissue marker for hypoxia, and this is an area that was hypoxic and low in oxygen. This area that is high in oxygen in the tumor. You see there is a lot of staining with HIF1 alpha. Same as this one. This is CA9 or carbonic anhydrase isoenzyme 9. This is again another enzyme that goes up, another cell marker that goes up with hypoxia, and this is the hypoxic sample, this is a hyperoxic sample. Same patient, you see there's tremendous difference in terms of what we see. Same VEGF. VEGF is actually the target of some medication treatment currently used in GBM, but again, see, this is a hypoxic area of the brain. This is hyperoxic part of the brain. There's a lot more staining with VEGF in hypoxic part. And the last marker we measured was CD105. And CD105 is an endothelial vascular marker that shows endothelial proliferation in neoplastic tissues primarily. So again, there's a lot more. You see these little dark blue ones. These are the CD105 positive, and there is barely anything positive here in same patient in the area that is less hypoxic. So what we tried to do, we tried to just come up with an imaging technique showing pathophysiology beyond structural imaging with the hope that we can incorporate it into clinical practice. What we want to know, we want to do as our next step is to implement it. So we want to see how much these hypoxic areas change over the course of treatment. And as the next step, we want to see, okay, what if we target these areas? As a clinical trial, we want to say, okay, we'll be more aggressive with radiation to these areas, and is this going to make any difference in these patients? So that's what I showed you in terms of evidence. What I really need to emphasize again, these kind of projects are extremely expensive. They are very, very expensive. The grant from Brain Tumor Foundation of Canada let me got another grant, and because of both grants, I could run the project. This is a very, very costly project, and research is extremely, extremely expensive. And without help from the organizations and foundations like BTFC, these kind of stuff is impossible to do. And I'm ready to take any questions.